Bismillahirrahmanirrahim. We will start with quote of the day, which is from Quran. Indeed, with me is my Lord; He will guide me. Today's topic is growth chart, importance, parameters, interpretation, and Pakistan's context. I am Dr. Taimia Ayub, and I will be presenting this topic under the kind supervision of Professor Dr. Saira Afzal at Institute of Public Health, Lahore. These are the learning objectives of today's lecture. So we will start with the definition. What is actually a growth chart? A growth chart is a statistical reference showing distribution of anthropometric measures by age and sex. For example, weight, length or height, head circumference. Clinically, charts show where an individual child lies relative to a reference population, percentile or z-score. From public health perspective, aggregate charts and population z-score distribution indicate nutritional status and program impact. So, what are the key anthropometric measurements? These are weight measured from birth, crucial for assessing nutrition, length or height, length for infants while lying down, and height for children standing. Head circumference, essential for infants and toddlers 0 to 2 years to monitor brain development. Body mass index, calculated from weight and height for children over 2 years to assess overweight and obesity. Mid upper arm circumference, used globally, especially in resource limited settings, to quickly screen for malnutrition. Then we have some cutoff values and the concept of z-scores and percentile. Z-score is actually observed minus median of reference divided by SD of reference. Indicate how many standard deviation a child's measurement is from the mean, highlighting growth issues. For example, minus 2 SD suggests risk. Common cutoff used by WHO are for stunting. Height for age z-score is minus 2, less than minus 2. Severe stunting, it's minus less than minus 3. For wasting, weight for height is used and its z-score is less than minus 2. And for severe wasting, less than minus 3. For underweight, weight for age z-score is used and for that value is less than minus 2. Overweight and obesity, weight for height is used and when the z-score is beyond plus 2 or BMI for age threshold. And BMI for age detects overweight, obesity or underweight in older children. So these are some of the measurements which I was trying to explain in the previous slide. You can see this is a normal individual. This is known as wasting. The height is the same, but weight is less. So it is low weight for height. Then we have stunting, in which, as you can see, the height is less. So in this particular case, it is low height for age. Then we have underweight individual who has low weight for age. And then we have overweight or obesity in which the height may be same but weight is more. And then there is double burden in which stunting, low height is also present along with overweight. So these are some of the scenarios. How growth charts were developed. WHO Multi-Center Growth Reference Study MGRS 1997 to 2003 gathered data on healthy breastfed children across 6 countries to create an international standard for children 0 to 59 months. For older children 2 to 20 years, WHO and CDC provide reference charts. Um, this is an example of what a growth chart looks like. There are many different examples for different ages and for different parameters. So this particular growth chart is for weight for age girls. So you can see it is pink in color. So they have segregated the boys and girls chart by by blue and pink color. And this particularly is for weight and for kids between 2 to 5 years. So let's have a look at this and then I will explain the components later on also. So as you can see, it is pink in color. On the x-axis, we have years or months in age. These are the big years. And then in between, we have at 2 months interval, we have months 2, 4, 6, 8, 10, and this is the next year starts. And on y-axis we have weight, and it is in kilogram. It starts from 7 8 and it goes on till 30, and on the this side there is again weight is present. Okay, so we have a green line, we have two red lines, and we have two black lines. And as you can see, the green line here it says 0, and then for the red lines it says 2, and then here it says -2. And for the black line it says 3, and the lower black line says -3. So we will explain later on. Basically this is the, in if we are talking about in the percentiles, this is the 50th percentile. Some growth chart also show percentile here instead of the z-scores. This particular one is showing the z-score. So if there was a percentile here, this would have shown 50th percentile. So let's move forward. Okay, so this is again the explanation of the component of the growth chart. We have x-axis and y-axis. X-axis is showing age, usually in months for under 5 children, years for older children. Y-axis is vertical, shows the anthropometric measurement depending upon the chart. It can be weight in kilogram, length or height in centimeter, or BMI, depends on what we are measuring. So we have these curved lines which can represent z-score or percentile lines. Central line is the middle bold line which shows 0 z-score or 50th percentile. It represents the median of the reference population. Then we have other curved lines. They are usually labeled as +2, +1, -1, -2, -3 z-scores depending upon. These lines show how far a child's measurement deviates from the median. Clinical meaning, as I have told already, that between -2 and +2 is the normal growth. So a child, if it is anywhere here between -2 and +2, it is normal growth. If it is below -2 z-score, it is undernutrition. And it is, if it is above +2 z-score, it is overweight or obesity. Okay, so in some older charts, they also showed colors. Like this is an older growth chart, which I have shown on the right side. And here they showed colors on the growth chart. And in this, green area showed normal range, yellow or orange area showed moderate risk or moderate malnutrition, and this is the orange or red area which showed severe malnutrition or beyond -3 or z-score. Again, this is for length for age. So the previous one was weight for age for girls, and this is length for age. And you can see the time period here is birth to 2 years, and it is in percentile. So it is 50th percentile, 85th percentile, 15th percentile, and 3rd percentile. And here it is 97th percentile. So this is a growth chart from World Health Organization showing length for age for girls from birth to 2 years, and the measurements are given in percentile. Again, on the x-axis we have age in months, and here the months are only spaced by 1 month, 1 2 3 4 months, like this. And on the y-axis we have length in centimeters. So this is how it goes. So this is growth chart for weight for age for boys, and this is from birth to 5 years. There are different versions which have been printed. Some are birth to 2 years, and some are and 2 to 5 years, and some combine both these time period, and they are from birth to 5 years. So it depends. There is not much difference. Again, you can see on x-axis we have age in months, and there is a interval of 2 months. And then on y-axis we have weight in kilogram, and then we have these lines, green lines showing 50th percentile, oranges line show 15th and 85th percentile, and red line shows 3rd or 97th percentile. So again, it's the same case. It is length for or height for age. In boys, it is showing from birth to 5 years z-score. X-axis, we have again age, and y-axis, we have length or height. And there, this is showing z-score. So we have 0 z-score and 2 and -2. So in between these two is the normal growth, and then we have 3 and -3. So Whether you are taking percentile or z-score, as you can see, it nearly means the same thing. It is just how they are measuring it or comparing it. There is not much difference. This is again for the head circumference for age, and here they are also mentioning 1 and -1 for z-score also, and rest of the things are the same. Okay, so this is taken from World Health Organization site, and as you can see, this is only for the length or height for age score, and this was all the information which was available there. So girls chart for age birth to 6 months, girls chart length for age birth to 2 years in Z scores, and similarly 6 months to 2 year in Z scores, 2 to 5 years in Z scores, and birth to 5 years. So all these different variations are available in on WHO World site, and this is for all the charts for the girls, and this is for the boys. And then similarly, same calculations are also available for the percentiles. As I was showing you just before, there are different charts, some with the z-score, some with the percentile. So all these are available from World Health Organization sites. Similarly, this is for weight for age, for girls, for boys, with z-scores and with percentiles. So, why growth chart matters? Early detection of faltering or excessive weight gain and to guide clinical decisions, feeding support, medical evaluation, referral for acute malnutrition. Track response to treatment, for example, recovery from wasting. Emphasize serial management, measurements rather than a single point. Use plotted trajectories. So, one thing I want to add here that for growth chart, where a child is present on it is very important, but the most important part is their comparison with their own previous points of measurement. So if a child is in the on the line of -2 z score, okay, so if I can explain it here, if a child is on this trajectory, -2, and he is going on this, it is not that good, but it is not in the dangerous level. If a child is on, for example, even in the zero trajectory, and after some illness the child goes into this area, so in comparison to their own previous measurement, the child has stopped, or decreased in height, or the height is not increasing basically. So this is more dangerous than a child following their own path, because in comparison to the previous measurements of that particular child, that's what their height trajectory is. But if due to a illness or some malnutrition or some problem, they have stopped growing suddenly, this is more dangerous. So, serial measurement is more important than a single point to show the trend instead of just one measurement. Why growth chart matters? Again, to estimate population prevalence of stunting, wasting, underweight, and overweight, monitor secular trends and program impact, for example, from nutrition, wash programs, and social protection. Target intervention geographically or by demographic groups. And then we have measurement in quality and practical consideration. Accurate age in months is essential. If there is any error, it will distort the growth chart. Standardized equipment and technique. Length boards for infants and stadiometer for older children with calibrated scale. So for infants, as the word height, we use length instead of height. So length boards are used in which the infant lie down, and their one side of their body, which is usually the head, is fixed, and from the foot we measure their length. And stadiometer is for the older children, in which they will stand and the observer will take the measurements. And then to train the measurers, check inter-observer variability, periodic calibration. These are very important. Plot serial measures and interpret trends, not single reading. Again, this is what we just explained. So, common pitfalls and limitations: use the wrong chart for age or sex, single measurement interpreted as trend, reference versus local population differences. Charts are standards, not growth goals for every child, non-nutritional cause of growth faltering, for example, chronic disease, congenital disorders, and so on. So, globally, progressive is uneven. Global stunting and wasting remains substantial. Childhood overweight or obesity is rising in many regions. Recent interagency JME report indicates insufficient global progress towards the targets for the nutrition and child growth. Global statistics related to growth chart parameters. Children under 5 years for stunting or height for age less than -2 z score, about 150 million children globally, about 23% of the world population is stunted in children. It reflects chronic undernutrition. Highest burden is in South Asia and Sub-Saharan Africa. And wasting, which is weight for height, less than -2 z score, 43 million children globally. It indicates acute malnutrition strongly associated with child mortality. So you can see what they reflect for stunting, it reflects chronic undernutrition, and wasting indicates acute malnutrition. So this is also important. What measurements we are getting from growth chart, and what are they representing? So highly sensitive to conflict, climate shocks, and food crisis. So for Pakistan, stunting, which is in less than 5 years of age, about 37 to 40% are said to be stunted, which means that 4 in 10 children are with chronic undernutrition. Wasting, which shows acute malnutrition, about 17.7% is of the children in Pakistan are wasted. Swear wasting is about 6%, and similarly, underweight children are also in a large number. So, what are the drivers and contextual factors related to Pakistan? Poor infant and young child feeding practices, low rates of minimum dietary diversity, and suboptimal complementary feeding. Maternal malnutrition and anemia, for example, 14% of the women are underweight and high anemia is present, and this leads to the presence of these similar conditions in their children. Food insecurity, poverty, water sanitation gaps, recurrent shocks, floods, displacement, and health services across excess inequalities. So, malnutrition varies by province, rural, urban location, socioeconomic status, and district level, uh, depending upon the conditions. So Pakistan is trying to respond to this by Pakistan multi-sectoral nutritional strategy, and related federal and provincial strategies aim to coordinate nutrition action across health, food security, wash, and social protection. And similarly, maternal nutrition strategy 2022 to 27 emphasizes antenatal nutrition and supplementation. Similarly, community-based management of acute malnutrition, CMAM, and other programs like micronutrient supplementation, fortification, supported by government and partners, are trying to make the situation better. So, when a patient presents, we measure their weight and length or height, plot on appropriate WHO chart, and compute Z scores or percentile. Use MOAC for rapid community screening where appropriate. If Z score is less than -2 or MOAC below threshold, evaluate for acute causes, treat or refer per CMAM guidance. Track weight, velocity, and counsel caregiver on feeding, illness prevention, and follow up. So, this growth chart is also used for interpreting trends and program evaluation metrics. Program indicator, prevalence of stunting, wasting, prevalence of swear wasting, exclusive breastfeeding rate from 0 to 6 months, coverage of CMAM, dietary diversity, and similarly, adjustment for measurement error and seasonality when evaluating programs. So, uh, growth chart can also be used in community setting for evaluation of programs. So, what can Pakistan do in current situation with so many undernutrition and actually overnutrition both? Scale up community growth monitoring plus CMAM in high burden districts. Strengthen maternal nutrition. This is very important. Improve IUICF practices through health workers training and maternity protection. Address multi-sectoral driver like wash, food security, poverty reduction, fortification, and school-based program. Invest in measurement, quality training, equipment, routine data systems, and district level use. Again, these are the similarly the three levels of prevention which can be applied. For primary prevention, entire population, including pregnant women, infants, and young children, should be targeted. Similarly, as I have explained, that we should focus on maternal nutrition, exclusive breastfeeding, timely, adequate, and diverse complementary feeding, food security, micronutrient fortification, wash programs, immunization and infection prevention, healthy diets, and physical activity. These are all key interventions. And some of another important thing is to maintain children within normal growth chart, and this happens when children are and their parents are actually made aware that they should regularly go to the doctor and have their growth chart monitored on a chart. Prevent population shift towards stunting, wasting, or overweight. For secondary prevention, for any children showing early growth faltering, we should start with routine growth monitoring using WHO charts, MOAC screening at community level, early identification of either stunting or wasting, outpatient management of uncomplicated acute malnutrition, targeted feeding counseling, and micronutrient treatment. And yes, for tertiary prevention, when the child has developed severe or complicated malnutrition, then key intervention is inpatient management of severe acute malnutrition with complication, therapeutic feeding and medical stabilization, nutritional rehabilitation and catch-up growth, long-term development, follow-up, and social support. And role of growth chart is to monitor recovery and catch up and monitor outcome. So this is an article from American Academy of Pediatrics. It was published on 18th August 2025. It focuses on creation and evaluation of new growth charts with a gradual transition from WHO to CDC values. So, at age 2 years, the Center for Disease and Control and Prevention recommends switching from World Health Organization growth standards to CDC 2000 growth reference. This abrupt switch may affect growth assessment, such as causing a clinically important change in growth Z score in a child with stable growth pattern. We sought to create growth charts that gradually transition between WHO and CDC and to evaluate their impact on growth assessment of young children using real world data. So, in conclusion, they said we created growth chart that gradually transition between WHO and CDC and may reduce over-identification of slow weight gain. These charts may be useful in clinical care and research. So, WHO and CDC, although they have similar growth charts and measurement, there is still slight difference, and this is for the American population. So, when they shift from WHO to CDC, there can be over diagnosis of some weight gain, etc. So that's why they developed this growth chart for transition between WHO and CDC growth chart. So this was the latest research development. Now we come to multiple choice questions. So, MCQ number one, on a WHO height for age growth chart, a child's plotted point lies at minus 2.5 Z score. How should this finding be interpreted? Normal growth, moderate wasting, stunting, severe wasting, or overweight?
C.
So, for this is height for age Z score, and the child is minus. Yes, so it is stunting, which is related to the height. The rest of the parameters are related to the weight. Which growth chart parameter is most appropriate for identifying chronic undernutrition in a population? Weight for height, BMI for age, weight for age, height for age, or head circumference for age?
D.
So, it is weight for height because this shows wasting, which is for chronic undernutrition. A 14-month-old child shows flattening the growth curve over three consecutive visits. Although the current Z score is still 1.5, is still minus 1.5. What is the most appropriate interpretation? Child is normal, no action required, measurement error only, early growth faltering requiring intervention, severe malnutrition, or genetic short stature.
C,
Yes, early growth faltering requiring intervention, which should be checked. Which component of a growth chart allows rapid visual identification of children with severe malnutrition in community settings? Uh, is it the x-axis, y-axis, percentile labels, color-coded zones, or median lines?
C.
Yes, it is for rap. If we are talking about rapid visual identification, then color-coded zone is the easiest one to pick up. For community health workers using MOAC screening and identifies a child with low MOAC but no medical complication, which level of prevention is primarily being applied? Primary prevention, secondary prevention, tertiary, primordial, or quaternary prevention?
B.
E,
Yes. Um, it is B for particularly for growth chart. So it is a secondary prevention is being applied here. Globally, approximately 150 million children under 5 years are affected by which of the following condition? Wasting, overweight, severe wasting, stunting, or underweight?
D,
Yes, it
E.
is. It is stunting. For most of the children are affected by stunting. A country report reports high stunting prevalence with rising childhood overweight. This situation best represents which nutritional phenomena? Nutritional transition only, single burden of malnutrition, double burden of malnutrition, protein energy malnutrition only, or measurement bias.
C.
Yes, it is C, double burden of malnutrition, C. According to WHO standards, which z-score range represents normal growth on most growth charts? -2 to -2, -3 to -2, or B -2 to +2, C -1 to +1, D 0 to +2, or E +1 to +3.
B.
B,
Yes, it is B. Between -2 to +2, all the growth is usually considered normal. A child admitted for severe acute malnutrition with medical complication is being managed in a stabilization center. This intervention corresponds to which level of prevention? Primary, secondary, tertiary, primordial, selective.
B,
C.
No, it is C, tertiary center, because the severe acute malnutrition has developed. So, and he's being hospitalized. So it's tertiary. Why are WHO growth chart described as standards rather than references? They represent average growth of a specific country. They describe how children actually grow in poor setting. They are based on optimal growth conditions across countries. They are derived only from hospital data. They apply only to low income countries.
C.
Yes, it is C. They are based on optimal growth condition across multiple countries in different continents, actually. So this is the MCQ key. This is the YouTube channel where this video will be uploaded. And thank you very much for listening.
Dr. Taimia, it was a wonderful presentation.
Thank you.
And thank you.
Thank you very much, Dr. Ram.
thank you, Dr. Taimia.
Thank,
Thank you.
thank you very much.